So I think we started the morning wonderfully. The first session is like, to me, like a spaceship. We build this, it is going, searching for the answers in the space. However, we are down here, we are facing patients from day to day, so I think we need to do the best we can with all we have in our choices. And Jeff, thank you very much for summarizing as to what are available. And from the list, you can see that even in head and neck cancer, there are many, many diseases. And the way we choose our treatment now is based on site, stage, and I think we are starting to use some morphologic, histologic features to really select our treatment. So with that, why don't I ask the panel members to have a short remarks, and then we can open up this session for discussion, and I very much will encourage audience participation. So if you have questions, please do express yourself. I see there are microphones around, so if you stand up, you'll get microphone. So going in order, René, perhaps we can start with you as an experienced surgeon, saying that how do you approach treatment decisions in your day-to-day practice?
Well, thanks, Kian. First of all, I couldn't agree more with Jeff, of course, in many of his statements that he just made, but that's probably because he's a surgeon as well. First of all, I think it's paramount that you discuss your patients in the multidisciplinary team, and that's something that's still probably not that often done worldwide, and is becoming more and more en vogue. And I think it's paramount that treatment decisions are made multidisciplinary. And secondly, of course, the role of surgery in that setting is very much evolving, is changing lately, and I think maybe the pendulum on some indications has swung a wee bit too much to the non-surgical side, and will swing back in future times. But I think it's very interesting times for the head and neck surgeon. Although I heard in the previous session that we are only partly head and neck and partly lung and partly something else, maybe.
Well, I think that from the medical oncology perspective and the treatment of the locally advanced cancers, we've seen a tremendous change over the last couple of decades in now our integration of chemotherapy into very specific settings of the patient with more advanced disease that has a much higher risk of recurrence and death from their cancer, and also in our evaluation of quality of life and preserving attempts to preserve organ function. We have, as Jeff showed, there's a whole menu of different options. We have very established indications for using concurrent chemotherapy and radiation at the present time. That's based on randomized controlled trials, and we can discuss further those specific indications. And we're in an exciting time right now because we have identified more effective chemotherapy regimens that can be used in the induction setting. We have the biologic therapies, and our challenge is really how do we integrate these new therapies, and how do we determine which patients should get more intensified therapies, which patients would benefit from more intensified therapies versus actually stepping back and perhaps de-intensifying some of our therapies. So I'm going to stop there.
Yes, when we talk from the radiation oncologist point of view, I think we are treating with very aggressive treatments here, and they have a lot of side effects, toxicities, late effects. And from my point of view, it would be very necessary to have more stratification and more selective tools, as Dr. Mamberg showed us, where we can, like this, spare lots of our patients from superfluent or from excessive treatments which are not effective. And therefore, we are in the daily practice just bound to a T, N, M and the side, and that's it. And not even EGFR expression is a matter of daily practice at the moment. So we have a long way ahead of us. And as long as we search for these selective tools and, for instance, parameters for the future, we should very much, I think, deal with the treatment quality in a perspective of quality of life, because our patients, we address not enough the long-term quality of life of our patients, I think. And when you look at patients after 3, 5, 6, 7 years with the intensive chemoradiation, it's not always nice what we face there. So I think we should long-term evaluate the quality of life. We should more focus on this. And also when we, for instance, because we talk about general principles of treatment selection, we should also design our trials on a basis of, for instance, isotoxicity levels, which we expect in both arms of the trials, like this. Always compare the efficacy on the same level of toxicity, because when we have a much more toxic treatment in the experimental arm and we have there some more efficacy, what is it for us? It's not a real gain in therapeutic advantage. It's just more toxicity and, like this, also more efficacy. But we should try to have the same efficacy levels in both, the same toxicity levels in both arms. And in one arm, the experimental arm should have additive more efficacy. Then we have improvement of the therapeutic index, not in the other cases. So I think we have some measures which we can concentrate as long as we have not the new highly selective tools available for the daily practice.
Okay, Jeff, any other comments?
Well, I guess I'd like to say I gave sort of a one-sided introduction, and that really had to do, it's sort of following on the heels of a very scientifically driven talk, and that had to do with the science of medicine and tumors and what we know about them and our ability to predict how they behave. But the sort of art of medicine, or the patient side, and what sort of treatment they can withstand, tolerate, what their desires are and what their priorities are. So I think that has to be factored into the equation. I can just cite an example of a case I saw recently of a woman who was 83 years old who had a soft palate mass and some history of a lymphoma that was a fairly low-grade indolent thing, and this decision about whether to biopsy this palate mass to make sure that she has a definitive diagnosis to select treatment. She's completely asymptomatic. She has a excellent quality of life, is very active, but is also on Coumadin and aspirin, and will need to just do the biopsy is a big deal for her. Yet this is a stable disease. So the right thing for her, even though we might be able to pick a targeted antibody that holds this disease at bay, is maybe just to watch and wait. And I think those kinds of issues need to come into our decision making more and more.
Aline, you have comments?
Well, I was going to add to what my colleague was saying about toxicity and the fact that we actually have not done a very good job of capturing late events in any organized fashion. There's been a fair amount written about that lately, and the fact that less than half of clinical trials, if we look worldwide, actually report late events. And that's really critical as we go forward with these intense regimens and the addition of new therapies.
Okay. Before we go further, any questions or remarks from the audience? You have experts here. So, Bo, thank you.
First, an excellent discussion from the panel already. I wonder, Jeff, you alluded to papillomavirus data, and I think it's been, I'm not sure this is on.
Yeah. Maybe you can stand up. Yeah, you can stand up.
So Jeff's alluded to the papillomavirus data already, and some of the work looking at clinical trials, for example, in retrospect. One more time. Is this working? Sorry. Jeff alluded to the papillomavirus data, and some of the work specifically looking at clinical trials for oropharynx tumors treated with chemoradiation. Moragillison being the lead investigator on that, has shown an incredible response based on the papillomavirus status itself. Probably better predictor than staged on its own. Should predictors like papillomavirus and also similarly chemo response be incorporated as stratifying measures for future clinical trials?
That's a wonderful question. We will come back to that later. In fact,
One comment from a medical oncologist is essentially the kind of general principles for treatment selection and falls very well to the previous section. And if you compare the state of head and neck cancer treatment and treatment selection to other diseases, it is quite obvious that we are right now in the world to really develop the treatment selection for certain subgroups of it. And I was struck by the comment of the idea that if we do that, we have too few patients in every cohort. I think that is something we really have to overcome. If we look for the other extreme, for example, leukemia, we have used since a number of years now the subtype those leukemias, and to really look for very small patient subgroups because biologically that is necessary. And we cannot say that because politically or organization-wise this is impossible to subtype, that we accept that. We really have to make our efforts and subtype the tumors based on their biology, and there certainly is different biology in different sites of head and neck cancers, and make every effort to adhere to the biology of the disease and not to the head and neck region.
So we are dealing with how to select a specific group of patients for trial design, answering some scientific questions. So I think we can get back to that as well. Any other comments? Well, I think in my perspective, I love the analogy of the subway station shown earlier very well. So basically, we are here to prevent the cancer train from going from one direction into the ends, which is the worst outcome. And I think let's think about how to block the train. And in my view, in early tumors, small train, you do not need to know all the mechanisms and the rails because it is probably relatively easy just to take out the train and then throw it in the trash bag, right? So we are aiming for some single modality treatment because we know now that combining treatments, adding one to another is really increasing toxicity. I think now we have a multidisciplinary panel here. Let's see whether we have an agreement saying that in early tumors, we strive for a single therapy and how do you select therapy modality. And then after that, we will go to more locally advanced now that we know about the biology of EGFR, HPV, how do we really apply this in the future trial design? Why don't we start with the early tumor first, and Volker now, we are starting from here and then we'll go around.
I think there is no question about it's no question about that we have a very good chance for early cancer with surgery. And as long as there is not too extensive nodal disease, I think we have also very good results without any adjuvant treatment.